Today we're going to talk more about the shoulder girdle complex and about really what we're going to be talking about today is the scapula. Really what we're going to be talking about today is the scapula and everything that hooks to it. So I don't know if you guys remember, but like a week or so ago we talked about the 5 major muscles that grab onto the scapula and move it around. Now this is different from the muscles that move my arm as it connects to the scapula. This is just moving the scapula that's carrying my arm along. But today we're going to talk about like everything that's kind of attached to the scapula. And so we learned these bony landmarks of the scapula, or we started to learn them, by the way. It's okay if you don't know them completely. We're going to go over them again right now. But then we're going to discuss what attaches to them and why do we care. And the really cool thing about this is, this is probably already happening with you already, but for one of the first times, you're going to know when you put your hand down on a place what you're grabbing and what you're doing. And what's really cool about that too is it allows you to kind of know how you're manipulating this, at least this area of the body. And it's very exciting because very few massage therapists really get the scapulas. They can find them, but they don't really get what they're doing back there. In fact, sometimes they make some pretty big mistakes. But not you guys, because of today. Okay, so let's review a couple things. Can anybody tell me the 5 muscles that attach the scapula to the axial skeletal system? They essentially attach the scapula basically to the rib cage, essentially. But the 5 muscles that attach the scapula to the rib cage, I feel like Miss McDowell was about to say something before she was freaking out over there. What's going on over there? You mixing up drinks and stuff? Shaken, not stirred? Jeez, wait, 3 hours, wait.
No, it spilled into my drawer.
In your drawer?
Yes, my water.
Yeah.
One of the muscles that, you mean the ones that are on the scapula or the ones that just touch it?
So let me back up. Thank you for everybody. Your entire shoulder girdle complex, which is essentially your humerus, your scapula, and your clavicle, is attached to your body by one joint only. Does anybody know the joint that attaches that to your body? One joint only attaches your arms and everything, one joint. Now, by the way, there's loads of muscles to keep your arm from falling off, but there's only one joint that actually attaches. Who was that?
I was going to say the glenohumeral joint, right?
Glenohumeral joint attaches your arm. You are on the right track, sir. But what attaches your scapula and your clavicle to your body? What joint there? There's only one joint that does this.
Sternoclavicular joint.
Sternoclavicular joint is right. Everybody, right up here, feel this little notch here? If you push to the side of that notch, you are hitting the edge of your clavicle. And you are literally pushing this spot where your clavicle attaches to your sternum. This is your sternum. By the way, if you're poking this way, you're kind of choking yourself. But anyway, even over here, this is your sternoclavicular joint. It should feel kind of sore, actually, if you poke around there. It's a nice thing to do your boyfriend or girlfriend when you're reviewing anatomy. Be like, hey, oh, that's where it is. They're like, ah! Anyway, that is not, by the way, what makes your shoulders not fall off your body, but that's the only joint. This is a little bit unusual for your body to do stuff. Normally your joints are really big, like your hip joints, where things are locked in there and stuff like that. This, your shoulder girdle and everything like this, all this stuff back here is just hanging off muscle. It's not actually attached to your body directly with a joint. This is the only joint. And your clavicle can only take about 5 pounds of pressure depending on how you hit it. And so obviously the strength of your whole arms and all that stuff is not coming from this joint. So there's only one joint that attaches your entire arms onto your body, and that is your sternoclavicular joint right in here. In order to make the shoulder girdle complex work, therefore, this scapula back here, on this skeleton, by the way, I realize I've said some of this stuff multiple times, but I think that's how we learn it. It's not that I forgot that I've told you. This skeleton, the scapula is wired to this skeleton. They got 1, 2, 3, 4, 5, 6 wires holding the scapula on. On a real person, there are no wires. On a real person, if we found this skeleton, I guarantee you this would not be on the body. It would be over here somewhere, right? So this scapula is held onto the body with muscle, which is what gives it its key to being able to move so much and do all this stuff. And there are 5 muscles that tie the scapula, which is the appendicular skeletal system, to the axial skeletal system. That's what I'm asking. Anybody, what are those 5 muscles? Or anybody, what is one of those muscles? I was hoping you'd say something, Miss Lobitz. Miss Lobitz, take it away. We'll take 1, 2, 3, 4, whatever you got.
Pec minor?
Pec minor is 100% correct, Miss Lobitz. For the additional $1,000 that you will get upon graduation from Mr. Blygen, no. What is the sign for the pec minor? Yes. Yes, 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 yes. Super important, everybody. This is almost the exact size of the muscle, almost exactly what it does. I can't tell you the importance of this. So pec minor, there's another one in front. Do you know what the other one in front is? That's coming right from under here?
The serratus anterior?
Bam! That's the 2 muscles in front. By the way, the serratus is coming from in back, but we see it in front. So you got pec minor and you got serratus anterior here. And then in back, we've got 3 muscles that help tie the scapula onto the back. Do you want to keep going, Miss Lobitz?
No.
No. Would you? Okay, that's good. You took the whole front of the body. That's good. Mr. Placencia, sir, do you want to talk about the muscles on the back that tie the scapula to the axial skeletal system?
Yes, those muscles are the trapezius, the levator scapula, and the rhomboid.
Yeah. And these are the type of muscles we're going to talk about today. We are going to talk about something called the subclavius, which you could argue is in this group too, but it's very, very small. But we're going to be talking about these big ones today. And the cool thing is we're going to learn really about everything that attaches to the scapula today. It's a big day. Yeah. Okay. Sorry, somebody. Oh, sorry, Miss McDowell. Yes.
So I was actually making flashcards earlier, and the lat, it touches it, but it doesn't like connect on it. Is that right?
The lat.
Because it touches the little part of the inferior angle.
Yeah, I think it actually attaches to the inferior angle.
Okay.
But we don't call it a scapular mover. By the way, not because that's wrong. It's correct, but its main job is to grab onto the arm and pull the arm, right? It grabs on the scapula because it helps pull that whole thing together, but it's not attached to a big enough area to make a big difference. So we would count it more as a glenohumeral joint mover than a scapulothoracic mover. You could argue quite easily it does both. It does cross over both joints.
Okay.
So I'm giving you kind of a lame answer. For your book and your teacher prefers to kind of put it as an arm mover. However, it really is both. It really is what we call a very significant muscle because it crosses 2 joints, and you could argue it moves both. Yeah. But we're not going to argue that today. We're going to stick with the 5. All right? Don't try to sneak a 6th one in there. Okay? All right. When you graduate, you can rewrite the textbook. No, you're right. Anyway, it does attach to the scapula. All right, so we got these 5 main muscles that are really meant to glue down the scapula. There are some ones doing a drive-by and hooking to the bottom corner or whatever. That was very astute of you, by the way. And let's talk about those. Let's talk about how we attach the scapula to the body, and I really, really need you guys to pay attention and try to visualize what we're going to do today, because these are the hardest. When I show you why, you're going to be like, oh, I get it now. These are the hardest muscles to visualize, and in my other class, we're 6 months in, and I still have students going, oh my God, I didn't quite get, because it's really tricky what goes on here. But you'll be able to use this information to create your own moves and do all sorts of cool stuff. Yes, yes, that's right. I said your own moves, and I said cool stuff. Okay, So let's talk about some things here. I'll show you a slideshow in a minute, but let's just talk about like walking up the edge of the scapula and what happens when we walk up the edge of the scapula. So a lot of you have probably already worked on a little move where you grab the edge of the scapula on somebody. Have you done this to anybody where you grab the edge of their scapula? You can, on a healthy individual, on just about anybody, by the way, you can grab that scapula, and if they're loose enough, you can lift it up and you can bury your fingers underneath it. I can get my fingers to disappear under a lot of people. Just a couple knuckles in. Disappear under there. And the reason you can do that is the scapula it's not a joint back here. I call it the scapulothoracic joint because it moves around, but there is no joint here. You can't do that in the shoulder. You'd kill somebody. You can't stick your fingers in. I mean, you can a little bit, but you can't, So this is because this is a free-floating bone back here that is attached with all this muscle. All right. So, from the inferior angle on the medial border, sorry, we're going to be talking about the medial border of the scapula, from the inferior angle roughly up to the spine of the scapula, we've got a muscle that likes to go diagonally over here to T2, the spinous processes of T2 through T5. What muscle is that? Rhomboid. Rhomboid major to be specific, right? Rhomboid minor is on top of that. So first let's do a couple little things to make sure we know what we're talking about. Let's see, Mr. Tate. This is a little off topic, so just bear with me. What region of the body am I grabbing right here?
Oh God, there's so many C's.
There is. It is a C though. That's really good.
I want to say clavicular.
Actually, clavicular was really close because that's your clavicle. Now I gotta think for a second. Cervical.
Cervical.
Cool. All right.
I kind of.
Yeah, you really did kind of know. That's exactly right. Cervical. How many cervical vertebrae do you have?
Okay, 7.
Yeah, 7.
7.
So C1, C2, 3, it's down to C7 here. What is the next vertebrae under C7?
It's T1, right?
Yes, sir. Thank you. That's exactly the answer. T1, that's T stands for thoracic. How many thoracic vertebrae are there?
12.
Yes. So what makes a thoracic vertebrae a thoracic vertebrae?
It's in the thoracic region?
Yes, but what makes it in the thoracic region? That's a great answer, by the way. And don't feel...
because it's the ribs?
Yes! Thank you. Thank you. Thank you. Sorry, I've asked that question not just in this class, but to another class like 7 times today. Yes, it's because anything associated with the rib is the thoracic region. So if a vertebrae is associated with the rib, it's a thoracic vertebrae. If there is a rib present, you're in the thoracic region. Rib, thoracic, same thing. Good. All right. Now, let's make sure we got a couple other things straight. You're off the hook, Mr. Tate. That was fantastic. Miss Walker, why? Hello. Miss Walker, these are vertebrae. These are actually probably lumbar vertebrae. They're really big. But it doesn't matter. What do we call these things poking out the back that you can actually feel on somebody's back?
We talked about that yesterday.
We did? Good. I'm glad.
Money mesh. I don't know.
Okay, that's okay. Okay, they're a process, and they're on your spine. So, process on your spine, maybe flip those 2 words and just say them.
Oh, spinal process.
Yeah, spinous process. Spinous process, and by the way, I don't know if we've talked about this very much, but these ones coming out the side, those are transverse processes. Cool.
Got it.
You got it. Okay. Do you think everybody else got it?
You should ask somebody else.
I should, because I don't really trust these guys. All right. Okay. Let's see, Miss Trotter. What's this thing poking out the back of the vertebrae?
Spinal process,
Spinous processes, yeah. What are these things coming off the side?
the transverse process.
Yeah, thank you. Okay, just checking. Miss Vincent, what are these things poking out people's backs? Like dragon spikes.
Spinal processes.
Yeah, spinous processes. What are these things coming off the side?
Transverse.
Transverse. Cool. All right. I think we're good. Okay. So let's go back. So let's see. We got to go 2, 3, 4, 5, 6, 7. 1, 2, 3, 4. Okay. So this is T5 down here. Spinous process at T5. Now this should work pretty good. Let's see. We're going to build a fake muscle here. T4, T3, and T2. Yeah. Now there's some things that aren't accurate about what I'm doing. For one thing, I had the tape over here, but the rhomboids don't go over there. They just go to the edge of the scapula. Do you know what I mean? They just go to the medial border. But I had to kind of get them to come over here so they'd stick. All right? That is about the exact size of the rhomboids. Cool? It attaches on the medial border from the inferior angle up to roughly the spine of the scapula. Now, let's put in the rhomboid minor. Minor's usually, but not always, right on the shoulders of the major. That's just how I remember it, because I used to take my little girl and put her on my shoulders. It was her favorite thing, and ride her around like that, right? So, T1 and C1. So, some things to help you remember this. This is about the size of the rhomboid major. This is about the size of the rhomboid major. How many spinous processes does the rhomboid major attach to? Rhomboid major.
3.
Well, let's see. T5, T4, T3, T2. So it actually goes over to 4 processes. The minor is half the size of the major. How many processes do you suppose it goes to? 2. T1 and C7. So you got 6 processes in all, which is about the size of this guy. Cool. Now, there's a lot of cool things about just this alone. Here's one of the cool things about it. Can you see the angle it's running at? So this should inform you without looking at your book. I looked at your guys' homework. It was good. It was quite good, actually. It was quite correct. But without just memorizing it or cutting and pasting it, can you tell me the action of this muscle? What are some of the, I don't even care if you get them all. What are some of the obvious things this muscle will do if this tape got shorter? If this tape got shorter, remember the spine's not going to move. The scapula is going to go somewhere. The spine is the origin, the scapula is the insertion. What's going to happen to that scapula? Somebody. Raise your hand. Somebody. Who? Yes, Miss Estes.
It's going to adduct the scapula.
Yeah. By the way, what she just said is probably the number one thing to remember. It's going to adduct or retract the scapula. Yeah. It's actually, it looks like I'm throwing my chest out here, but what I'm really doing is pulling my scapula back. Adduct the scapula, we also call that retracting the scapula, but I'm not correcting you. Adduct is actually probably even the preferable way to say it. But retract, adduct the scapula. Anybody else want to add to that? That's the number one thing to remember about it. Yes, I just don't know hold on. Oh, sorry, Miss Suriel, yes.
I just got a question. It doesn't rotate also the scapula?
It does, and I'll explain that in a second. It's a little trickier to see. But let's get it does rotate the scapula.
Oh.
Because it's at an angle like this, believe it or not, if it pulls, it's actually going to rotate the scapula down because it's going to pull the bottom up and the top, where we measure rotation from, is going to go down. So it's actually going to create this action. You don't do it that often in life, rotate your scapula down. Gravity normally takes care of that for you, but sometimes you do. It will rotate the scapula down. What's the last thing it'll do? Because it's angled. Anybody know? Ms. Suriel, you still have your hand up. Do you want to comment? No? No? You sure? Change your mind. Or you can just be like, I don't know.
Elevate.
Thank you. It is going to actually, technically speaking, if no other muscle messed with it, that never happens, but if no other muscle messed with it, it would actually adduct and elevate at the same time because it's going diagonal. Now your body can stop it from elevating or adducting depending on what other muscles are pulling on it and all that kind of stuff. But that's exactly right. I don't care about the elevating as much. You'll see why in a second, but it's an important elevator, don't get me wrong. So it can elevate, adduct, pull the scapula closer to the midline, and it can even downwardly rotate. And we're able to see that, or at least start to see that. I much prefer what we're doing right now than actually memorizing what the book says. Okay, that's one cool thing we can do from knowing about this. The second thing is when you grab somebody's scapula, you now know that your fingers are literally plunging through, they won't separate them by the way, bending them and stretching the rhomboids. It's one of the reasons I like that move of grabbing the edge of the scapula is because in grabbing this edge, I'm grabbing the rhomboids major and minor. That's just a good thing to know. And if I pull out this way, if I grab the scapula and pull it away from the body and abduct it, I am stretching the rhomboids because I'm doing the opposite of their action. If they adduct and I abduct, and you can pull hard. Remember, somebody can hang from their arm. So when I grab your scapula, and I'm not exaggerating on this one, when I grab your scapula and pull, not all at once, but pull, I am more afraid of pulling you off the table than I am of hurting your scapula. I can pull you off the table before I hurt your scapula. As long as I go slow. And I mean that literally. I can pull you off the table, drag you down the hallway before I will do it with one of you too. Don't test me. All right. Anyway, so that's kind of cool to know. That's kind of cool to know that if we start at the inferior angle, we can run up here and kind of come up here. Now, the other thing that's kind of cool is, do you guys see the difference between the rhomboids minor and the major? Who sees the difference? You do, Miss Rotson? You see the difference? What's the difference?
The little guy's on top of the big guy.
Yes, you're absolutely right. The little guy's on top of the big guy. But do you see the difference? Like if I just brought you in today, would you see the difference between the two?
When I first was learning about them, I would picture them lower. So I'm glad we went over it again because it's like right in that supraclavicular muscle, but down and over. So I have a better, understanding of where it is.
Sure. Good. I would argue with you guys that there is no difference.
Okay.
So there was a trick question. Yeah.
I was gonna ask. Yeah, my question was if the little one made it go up.
Yeah, they both do the same thing because they're all going diagonal like this. By the way, you gave the best answer possible, Miss Routson, which is the minor's on top of the major. Okay. But I'm telling you, if we...
Same Zeus though?
Yeah. It's like, remember when I said if I say infraspinatus, you say, what do you guys say if I say infraspinatus?
Teres minor.
Yes. And if I say latissimus dorsi, you say?
Uh-oh.
Yeah. Teres major.
Teres major.
Yeah. Cool. Thank you, Mr. Tate. He was going to jump in there. These two are even more like that because, like, when you hear me talk about them, I'll usually just say rhomboids because to me, Yeah, I hate to use these, well actually, I don't know if I hate to use these examples, I use them all the time. If we went out and killed somebody today and stripped the skin off their back, I don't think we'd be able to find the difference between the upper and lower rhomboids. They're just rhomboids to us. It's just a big square here. Anyway, by the way, they're called that because they're a shape. They're a lopsided, they're a rhomboid, a lopsided square. Anyway, so rhomboids major and minor, or just the rhomboids. Great, we got those now. Let's keep going up the border of the scapula. Why don't we just learn the whole darn thing going up the border? So if I keep going up the border, I've come up from the inferior angle. You can actually do this on a person. You should do this on a person. I do this on every client I work on pretty much. Coming up the border, I got my hands underneath there, I'm pulling on this thing, I'm dragging them down the hallway, stretching out the rhomboids, and I keep going up, and I get up past the spine scapula. I'm still working on this guy. There's some scapula up here people don't realize up by the superior angle. What's a muscle that comes off the superior angle that was in your homework last night? Yes, Mr. Blygen.
What was the question again? I heard you, but
Well, you can't buzz in if you didn't know the question. I said, what is a muscle that has an insertion or an attachment, but insertion to be specific, on the basically the medial border next to the superior angle of the scapula?
So we went over the, no, it's not the serratus anterior.
No.
Or is it? No, because that goes on the anterior side. I would say the levator.
Good.
Or the erector.
No, say levator scapula.
Yeah.
All right.
Levator scapula.
Yeah. So essentially, everybody, levator scapula essentially looks like that. It's hard to do a tape, right? And the levator scapula hooks to the transverse processes of C1 through C4. Those are coming out the side of my neck. That's on the sides of my neck. Transverse processes of C1 through C4, and they insert into my scapula. Okay? And that completes the posterior side, the back side of the medial border of the scapula. I can now run my hand up a scapula and be like, rhomboids major, rhomboids minor, although I don't know when I get to the rhomboids minor, but I'll just know rhomboids major, rhomboids minor, levator scapula. And you can actually hit this one. This guy's a little tricky because he's way under the traps. We'll talk about it, but he's there. And your client will definitely know when you hit it. In fact, sometimes we come from here to get to it. But anyway. Okay. Cool. What?
Question before you move on.
I'm not moving on.
Is
Ever.
there a contraindication for doing, like digging into the scapula, like if the client has a specific something that wouldn't be a good thing, or should it be okay pretty much for all clients?
It's the only contraindication is fire. If your client is on fire, don't grab their scapula. But as long as they're not, you're good. There is no contraindication, sir. None. Yeah. You're cool. It's really cool. It's a real safe joint to work with. Good? Yes?
Yeah, I guess I'm asking more so like if they had an injury in the past, like in that area, would that be something that you wouldn't want to do?
No, I
Like,
still
just
think
on my
you're
shoulder.
still essentially okay. I worry about making blanket statements, right? Because we're going to find some client out there where it's not okay. But essentially, this is a free-floating joint. I have on many elderly people grabbed their scapula, lifted them way up, judiciously and slowly, but way up. Got my fingers under there without any problem. It is essentially safe to do on somebody. I guess if they tore their rhomboids outright or something like that, yes, you know what I mean? That's a very unusual injury. Essentially, you can do this to anybody. There essentially is not a contraindication, which is why I was being a smartass and saying fire, because I couldn't really think of, Yeah, it's a good question, but I would be careful up in the neck, not because it's super dangerous, but because it's super sensitive. Right? So this isn't dangerous actually to do, but it's sensitive, rubbing people's transverse processes of C4 C1 to C4. Like, it's sensitive in there. There's a lot of stuff going on. But that shouldn't stop you from doing it either. That's fine too. You're good. You're good. So we run up this medial border and we've hit 3 muscles. And we now understand everything that attaches to the medial border. Let's talk about what the levator scapula can do. By the way, what's the number one thing the levator scapula can do based on its name? That's good.
Lateral rotation.
I'm so sorry, what?
Lateral rotation.
Not lateral rotation, although it probably can aid in a downward rotation as well. Because it'll pick this side up and go like that. But lateral rotations and medial rotations have to happen at this joint. We're still talking about scapula.
Elevate,
I'm so sorry, what?
elevate.
Elevate, yes, Ms. Munoz. It'll elevate the scapula. That's why it's called the levator scapula. Elevate the scapula. Boom. That's the big thing it'll do. Like I said, it could create a downward rotation by pulling this side here and helping lift up this one side and pulling down the other. That's possible too. Could it do anything to the neck? What? Anybody?
Maybe assist them in rotation?
Yeah, it can assist. Your book talks about it too, I suspect. It's probably a weak rotator of the neck to the same side. Yeah. It can also help in my neck bending over too, which, what do we call this? By the way, you were right, sir, about rotating.
Flexion.
Which
No.
yes, it's flexion, but it's most flexions in front of you. So what's this called when we go to the side? Lateral flexion. It can aid in a lateral flexion of the neck too, sure. Now, I don't particularly care about some of those more nuanced movements, except this little booger gives a lot of people a lot of problems because it's tied to their neck and to their shoulder, and it's tied to the transverse processes right here of the neck. And what do you suppose, what nerve bundle comes out of here and runs down underneath your clavicle and down your arm? Remember that plexus? Anybody remember that plexus? I love the faces.
Is it the brachial plexus?
All day long, it's the brachial plexus. The brachial plexus doesn't come out of just one vertebrae. It comes out of like 4, right up here, and then they kind of weave together and they go down underneath your axillary region and feed your whole arm. So it's a pretty important area, especially when people are experiencing things like tingling and numbness down their arms. Doesn't mean this is the problem, but it sure could be. So this is great. We now kind of know these muscles right along here, and we can kind of see what they do. They all elevate the scapula. These guys here pull it in, adduct it. This guy here elevates, probably affects the neck some with some lateral flexion, some rotating the same side, can help in a downward rotation. But the point is, they pull the scapula back here or up, back here and up. Cool, because they're on the back side. Yes, is it Mr. Blige?
Question.
Please.
Is the levator scapula, is that deep or superior to the trapezius?
I like the way you think, sir, because that's kind of where I was headed. It is deep. These are deep to the trapezius. It's actually why I put them on here first, because if we put a trapezius over the top of this, it's got to come second. So I'm not going to tape off the whole trapezius, but I do want you guys to realize that these are deep to the trapezius. So, trapezius kind of goes here. Yes, sir, go ahead.
No, I just lowered my hand, sorry.
Oh, okay. I got all excited. I thought you had another good question. All right. So, now, remember this green, if this is an actual trapezius, it's everywhere, right? If it's an actual trapezius, I'd have to cover all of this. I don't want to do that right now because I want us to be able to see what we're talking about. So, can you rub the rhomboids without rubbing the trapezius? Anybody? No. As far as I know, it cannot be done without a scalpel. Okay? Just saying. are always rubbing the trapezius when you rub the rhomboids. There's no choice. Now, we can manipulate stuff and move stuff around, stuff like that, but you're always going through the trapezius. We sometimes call it telegraphing. You're going through the trapezius to get the rhomboids. Let me ask you this, too. Does the rhomboids assist the trapezius, or the trapezius assist the rhomboids? Are they synergists sometimes? Okay, so I'm seeing nods, yes. Can you elaborate? Like, which fibers of the trapezius are synergists with the rhomboids? Mr. Placencia, please, sir.
Would do the middle fibers and the trapezius help the rhomboids add up the shoulder blades, and then possibly the upper fibers as well to elevate.
Yeah. Could not have said it better myself, by the way. So the main thing, by the way, your answer was perfect. The simplified answer is basically the middle fibers, the trapezius, and the rhomboids work together, right? They both adduct. He was intelligent enough and complete enough to also mention the upper fibers probably work with the rhomboids too, because the rhomboids can't elevate, and that's true. So basically though, when you're rubbing the middle of the trapezius here, or when you're grabbing the edge of a scapula, you're now grabbing the trapezius, wrapping it around, wrapping the rhomboids around the scapula and pulling on it, which is actually very effective. So anyway, middle trapezius and rhomboids work together very, very much so. Does the trapezius work with the levator scapula at all? It's under here. Yes? Which fibers of the trapezius work with the levator scapula? Okay. Upper fibers. Saw some people go upper. Yeah, don't bother to unmute yourself. Just don't stress. Go ahead. So the upper fibers very much so work with the levator scapula. Now, by the way, I want to be very clear. That does not mean they always work, and please don't ask me when they work because I don't know. There's probably 1,000 scenarios, but in general, they like to hang out together and do very similar stuff. So we've just done something really cool. We've now talked about the 3 muscles in the back that attach the scapula to the body, move it around in the backside, and we now know who works with who. So we now know when people have shoulder problems up here, it's not just trapezius we're worried about. We're probably worried about levator scapula. We now know when people are like, oh, I'm tight in my upper back, they're probably not just talking about trapezius, they're probably talking about rhomboids too. You can't go a day working in a massage place without somebody mentioning rhomboids. So, here's a funny little thing that a lot of massage therapists do, just so you all know. Who remembers the erector spinae muscles? Miss McDowell, what are they? What are the 3 erector spinae muscles from medial to lateral? Sorry.
The spinalis.
Yeah.
The longissimus, and I don't remember the last one.
Yep. Now, all right. That's all right. Iliocostalis. Yep. Now, by the way, this is not fair because the spinal erectors are underneath all this, and I didn't put them in yet. But what I wanted to point out is a lot of people are rubbing the back because they're trying to get the spinal erectors, and you should. You should be doing that. But what they'll do is they'll ride up the back with their elbow. These are deep, by the way. I'm sorry, it's not the way. I should have put them on first. I wasn't thinking about this. But they're following this muscle fiber up there. It's in kind of a channel of the back. It's very easy to follow. And all of a sudden they go bump, 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 bump. And they go, oh, there's knots in here. I had to get those knots out. It's fine. You might need to loosen the area up. It's not knots. They're going across fiber going this way, the rhomboids. And it's a real common mistake. And they'll work on those little suckers for a while, not realizing that you're irritating some area and stuff like that. And all you're doing is you've just come up something going this way, and you've run across fingers going this way, and so you go bump, 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 and you think that those are knots. They're not. They might be tight rhomboids, but rhomboids actually work better if you switch your hands this way and rub this way. So I'm not saying don't go up the back. Go up and down the back, please. Lots and lots and lots and lots. It's one of my favorite moves. But just remember when you're running across stuff, you might just be running across muscles going a different way, like running across railroad tracks on your car. Okay. It's one of the many, many reasons why you want to learn your anatomy. Okay, good stuff. And it's a mistake that like beginning therapists make too, because they get in here and then they think one of these is a knot and they dig away at it for hours. And the body isn't that way, right? You gotta kind of let stuff go sometimes. Okay, so we now know there's 3 muscles on the back that attach the trapezius. The scapula to the body. The trapezius, the upper fibers like to work with the levator scapula. The rhomboids major and minor like to work with the middle scapula. Also the upper scapula. With the upper trapezius, sorry. And now we know when we grab on the border of the scapula, the medial border of the scapula, that we now know all these muscles we're hitting. We're now hitting 3 muscles, rhomboids major, minor, levator scapula. And we can't help but grab the trapezius when we do it. Cool? Good. That's the easy part to understand. The next part is not so easy and super important. Okay, what were the 2 muscles, I think Ms. Lobitz told us, in front that also attach the scapula to the body? Anybody else besides Ms. Lobitz, though? She was already right once today. That's all she gets. What are the 2 muscles that attach to the body? Yeah, go ahead.
I'll say it.
Please.
So the pectoral minor
Yep.
and serratus anterior.
Thank you. Thank you, sir.
Exactly.
Yeah, serratus anterior and pectoralis minor. You did great. All right, we know the sign for pectoralis minor. So I'm actually going to go, it goes from the coracoid process of the scapula, which is a bone of your shoulder blade. This is part of your shoulder blade that sticks out in front. It's a very hard thing for us to kind of conceptualize because we think of shoulder blades as being on our backs. And you can feel yours. If you find your acromion process and you drop down a little bit, you'll feel something that's kind of sensitive in there. And if you dig around for a while, you'll finally find something that's kind of like a pencil eraser, and it hurts. I don't care what kind of shape you're in, it hurts usually. Yeah. What are you, massaging yourself there, June? I like it. She's like, perfect in massage school. Yeah, why not? Yeah. Okay. So, I tell you that because a lot of massage therapists hit this too and think it's a knot. All right, let's take this. It goes to ribs 3, 4, and 5. 3. 4. And 5. By the way, your book made these attachments very confusing. They should have just said it attached to the coracoid process over here, but they said it attached to the medial side of the coracoid process. They just mean the inside here as opposed to the outside, but it's just such a nitpicky point. I mean, it's nice to put in your homework, but I just want to let you know, it attached to the coracoid process, hooks it to the ribs. So, let's look at these guys. They're attached to the scapula. There's 3 actions they have. There's only about 2 I really care about. What are their actions based on this diagonal thing going on here? Somebody, tell me. Who raised their, why can I not see? Oh, Miss Trotter. Sorry, Miss Trotter, your hand is in the window of your house. And so the hand's white, your window's white, you know what I mean? Okay. So, Miss Trotter, what are the actions of the pectoralis minor?
It's depresses or depression.
Can we see that, guys? It would pull the scapula down. It's just going down. So it depresses the scapula. Yeah.
And then doesn't it downwardly ladder or
it could downwardly rotate because it's grabbing onto the edge here, and it could pull it down too. Absolutely. What's the other thing it could do since it's in front?
It's pulling it away, so it's
Yes.
oh gosh, what is it called? Is it adducting?
AB.
AB, ducting. I always get them confused.
Yeah. I actually don't care you get them confused because I love what you just did. I really think it's helpful to learning this stuff. You said it like in regular English, right? It pulls away, and then you try to translate that, right? You always want to be able to use the big words, everybody, and you also need to be able to explain them to a 5-year-old. Otherwise, you really don't get it. So you get it. Good. So it also, because it's in front, it pulls the scapula away from the back, right? So it pulls the whole scapula forward. We don't realize it, but my scapula is way back here. It's way up front here. That's not my arm moving. That's my scapula moving. That's a huge distance. Huge distance. What that allows me to do with my arm is incredible ranges of motion. Yeah. So that's beautiful. That's beautiful. By the way, pectoralis minor, pectoralis major, almost nothing to do with each other. They're in the same area, but they do very, very different things. So just get that out of your head right now. Yeah. Yes, who just, oh yes, Miss Estes, please.
Would that also be a medial rotation or no?
No, but your logic is right. So you are right, it is in the position to do a medial rotation, but it's not attached to the arm, which is the thing that can rotate.
Okay.
So we say a protraction or an abduction as it kind of comes forward, and it does seem kind of like a medial rotation. Like it comes here, right? But there's actually not rotating. Rotating happens in my arms. You know, does that make sense? Yeah, but it is kind of like medially traveling. You know what I mean? It's coming forward and it's coming towards the midline. I can see that. I mean, like your logic is right. Your logic is right. But we'd say no. We'd just say it's protracting, it's adducting, it's getting farther away from the midline and back, and it's coming around to the front. Now, by the way, just to kind of hopefully not confuse things, but the pectoralis major grabs onto the arm, and it's in front, and it looks very similar to this, and when it grabs, it can medially rotate. So that logic works. Good, all right. I can't tell you how much this type of thinking makes me happy. Because this is the type of thinking you need to have to figure out problems, create your own moves, and be a very unique massage therapist. I'd really rather you get the answer wrong every single time and be thinking the way you guys are all thinking right now, as opposed to the book says this. Cool. All right, I love this. Okay. Next, we're going to talk about the serratus anterior. But we're going to take a break first. We're going to take a break first because it's break time and because we're going to build suspense for the serratus anterior. Yeah. All right, everybody, I'll see you back in 15 minutes. 4:46, please. Thank you.
Everything in life is a negotiation. When you cross the street is a negotiation.
Beautiful experiment in neuroscience to illustrate this. And unlike most neuroscience experiments, this is one you can do at home. All you need is one of these and a couple of paintbrushes. Now, in the rubber hand illusion, a person's real hand is hidden from view, and that fake rubber hand is placed in front of them. Then both hands are simultaneously stroked with a paintbrush while the person stares at the fake hand. Now, for most people, after a while, this leads to the very uncanny sensation that the fake hand is, in fact, part of their body. And the idea is that the congruence between seeing touch and feeling touch on an object that looks like a hand and is roughly where a hand should be is enough evidence for the brain to make its best guess that the fake hand is, in fact, part of the body. So you can measure all kinds of clever things, right? You can measure skin conductance and startle responses, but there's no need. It's clear the guy in blue has assimilated the fake hand. Now this means that even experiences of what our body is a kind of best guessing, a kind of controlled hallucination by the brain. Now there's one more thing. We don't just experience our bodies as objects in the world from the outside, we also experience them from within. We all experience the sense of being a body from the inside. And sensory signals coming from the inside of the body are continually telling the brain about the state of the internal organs, how the heart is doing, what blood pressure is like, lots of things. And this kind of perception, which we call interoception, is rather overlooked, but it's critically important because perception and regulation of the internal state of the body, well, that's what keeps us alive. Here's another version of the rubber hand illusion. This is from our lab at Sussex. And here people see a virtual reality version of their hand, which flashes red and back either in time or out of time with their heartbeat. And when it's flashing in time with their heartbeat, people have a stronger sense that it's in fact part of their body. So experiences of having a body are deeply grounded in perceiving our bodies from within. There's one last thing I want to draw your attention to, which is that experiences of the body from the inside are very different from experiences of the world around us. When I look around me, the world seems full of objects, tables, chairs, rubber hands, people, you lot. Even my own body in the world, I can perceive it as an object from the outside. But my experiences of the body from within, they're not like that at all. I don't perceive my kidneys here, my liver here, my spleen. I don't know where my spleen is, but somewhere. I don't perceive my insides as objects. In fact, I don't experience them much at all unless they go wrong. And this is important, I think. Perception of the internal state of the body isn't about figuring out what's there, it's about control and regulation, keeping the physiological variables within the tight bounds that are compatible with survival. When the brain uses predictions to figure out what's there, we perceive objects as the causes of sensations. But when the brain uses predictions to control and regulate things, we experience how well or how badly that control is going. So our most basic experiences of being a self, or being an embodied organism, are deeply grounded in the biological mechanisms that keep us alive. And when we follow this idea all the way through, we can start to see that all of our conscious experiences, since they all depend on the same mechanisms of predictive perception, all stem from this basic drive to stay alive. We experience the world and ourselves with, through, and because of our living bodies. Let me bring things together step by step. What we consciously see depends on the brain's best guess of what's out there. Our experienced world comes from the inside out, not just the outside in. The rubber hand illusion shows that this applies to our experiences of what is and what is not our body. And these self-related predictions depend critically on sensory signals coming from deep inside the body. And finally, experiences of being an embodied self are more about control and regulation than figuring out what's there. So our experiences of the world around us and ourselves within it, well, they're kinds of controlled hallucinations that have been shaped over millions of years of evolution to keep us alive in worlds full of danger and opportunity. We predict ourselves into existence. Now, I'll leave you with three implications of all this. First, just as we can misperceive the world, we can misperceive ourselves when the mechanisms of prediction go wrong. Understanding this opens many new opportunities in psychiatry and neurology because we can finally get at the mechanisms rather than just treating the symptoms in conditions like depression and schizophrenia. Second, what it means to be me cannot be reduced to or uploaded to a software program running on a robot, however smart or sophisticated. We are biological flesh and blood animals whose conscious experiences are shaped at all levels by the biological mechanisms that keep us alive. Just making computers smarter is not going to make them sentient. Finally, our own individual inner universe, our way of being conscious, is just one possible way of being conscious. And even human consciousness generally, it's just a tiny region in a vast space of possible consciousnesses. Our individual selves and worlds are unique to each of us, but they're all grounded in biological mechanisms shared with many other living creatures. Now, these are fundamental changes in how we understand ourselves, but I think they should be celebrated because, as so often in science, from Copernicus, we're not at the center of the universe, to Darwin, we're related to all other creatures, to the present day. With a greater sense of understanding comes a greater sense of wonder and a greater realization that we are part of and not apart from the rest of nature. And when the end of consciousness comes, there's nothing to be afraid of. Nothing at all. Thank you.
Everything in life is a negotiation. When you cross the street is a negotiation. Getting your coffee at Starbucks is a negotiation. You're probably in 3 to 7 negotiations every single day. Your life could be in a completely different place just by improving how you negotiate.
Negotiators are working around the clock.
The deadline for execution is passed.
With us now to help break down the investigation, FBI Special Agent Hostage Negotiator, Christopher Voss.
My role as a hostage negotiator is to connect authentically with the victim, the victim's family, and with the hostage taker. Everybody really deserves to have somebody hear what they have to say. In my masterclass, I'm going to give you all the strategies and tactics that I developed as one of the top hostage negotiators in the world.
Hey everybody, welcome to the podcast. My guest today is Dr. Andrew.
You're the most normal guy I know.
Look, he's least likely if that crowd
exactly
to happen.
So, in any event, I was permitted to go back to school eventually.
Anti-C, trauma.
You know, I actually used to set a timer. He was like, it's impossible to be in a bad mood if you're smiling. We wouldn't have any depression on the planet if that's true. There's probably some feedback from the face to the brain, but it's not that simple. But the idea that you can self-reward the effort process is extremely powerful. Because what it means is that if you can recognize agitation, stress, and confusion as an entry point to where you eventually want to go, I do think that even just mental recognition can allow people to pass through it more easily. They think they're doing something wrong. And then rewarding yourself when you achieve any milestone, like, you know, running to a particular location if you're trying.
Bonkers. Or because she was an old lady, whether she'd had that she was blind. Very, very repetitive, very limited. And she had a sense of humor. She knew it was a hallucination, but she was frightened. She'd lived 95 years and she'd never had a hallucination before. A man called Charles Bonnet, and you have Charles Bonnet syndrome. There's nothing wrong with your brain, there's nothing wrong with your mind, you have Charles Bonnet syndrome. And she was very relieved at this, that there was nothing seriously the matter. Pierre. Another patient of mine had a different sort of hallucination. This was a woman who didn't have trouble with her eyes, but the visual parts of her brain, a little tumor in the occipital cortex. And above all, she would see cartoons. And these cartoons would be transparent and would cover half of the visual field, like a screen. And especially
Okay, and we're back. We are back for the riveting conclusion that I promised you about the serratus anterior, and I don't think I've oversold it. I really don't. So let me tell you why. Let's try to tape off the serratus anterior, and then I'll show you why it's so hard and why we care and all sorts of really cool stuff. Who can tell me, and you might have to look at your book, that's totally fine with me, what the origins and insertions of the serratus anterior are? Essentially hooks your scapula to your ribs, or your ribs to your scapula. That's a good thing.
The origin is the external surface of the upper 8 or 9 ribs?
Yep. Stop right there for 1 second. So that's the origin. Now, again, they made it sound really confusing, right? It's the external surface. All they mean, honest to God, is it's not hooked to the inside of your rib cage. It's the external surface. Now, we do care because that means it's palpatable. We can rub it. So it's hooked, but we would just say, if we were talking to each other, we'd say it's hooked to your ribs, right? It's hooked to the external surfaces of your first 8 or 9 ribs, right? Why did they not decide on 8 or 9? Why is it 8 or 9? Why is it not 8 or 9?
Because there's smaller and bigger people, so the muscles have to adjust accordingly.
Yeah, essentially, although we don't think it's even due to body size. Just some people have it hooked to 9 ribs and some people have it hooked to 8. So it comes sneaking out like this, and you kind of see it in the front. It almost feels just like meteor ribs on people, by the way. Like when you're feeling for it on somebody, it's just these kind of meteor ribs. All right. That's the origin. Where's the insertion, Miss Munoz?
The anterior surface, medial border of the scapula.
The medial border of the scapula? But wait a second. We just did the medial border of the scapula. The medial border of the scapula has the rhomboids, major and minor, and the levator scapula. We covered the entire medial border of the scapula. I know, we just did it together. Where does the serratus anterior attach? She's right, by the way. You're right, Miss Munoz. You're absolutely right. All right, so follow with me carefully, and I will try to show you guys. I even made a little model with tape to try to show you. This, here's the one that's not taped off. This is the medial border of the scapula, correct? We all agree on that, I hope? Okay. This is the posterior scapula. There's also an anterior scapula we don't see that's in front. The serratus anterior, if this is a scapula, all right, and these are your rhomboids attached to the medial border, right? Rhomboid major, rhomboid minor. I made them 2 slightly different colors, but they look the same. What's this up here? Yeah, levator scapula. So this is you looking at the back of somebody, right here, boom. That's the stuff we just went over, okay? This is the serratus anterior. It wraps around the rib cage. It's hooked to the medial border of the scapula in front. I'm glad that some of you look surprised because it's important. It's probably one of the most complex things in your body. It actually is connected to the rhomboids, really. The rhomboids are on the back side of the medial border, if there is such a thing, and the serratus anterior is on the anterior side of the medial border. And literally, if we very carefully, we have to kill somebody again. We have to kill a lot of people in this class. We kill somebody, we skin them, and then, I'm sorry, I hope this isn't like triggering anybody. I don't really mean it, and we carefully cut out their scapula, we'd still probably have their rhomboids running into their serratus anterior. So, let me be very clear about this. This is what you guys are used to. You're rubbing somebody's back, you can grab this medial border, all that kind of stuff. right? But if you kind of dig under the scapula on this side, there's the serratus anterior over here. Yes, Miss Routson.
Sorry.
Don't be sorry. You're fine.
There's just a lot of muscles and tape colors, and I'm a visual learner.
Yeah.
So can you just say the red one is the levator?
Love what you're doing.
Scapula?
Love what you're doing.
The blue one is.
Red one is levator scapula. Green here is rhomboids major and minor.
Okay.
This is serratus anterior.
Okay, thank you. That's all I needed.
No, you probably need more because I'm still confused, but I really appreciate you asking that question. So I'm going to try to show you on my body a little bit, but it's really kind of hard to do. But if this was my scapula, it would be back here like this, right? We can see that. And this serratus anterior actually would come around my ribs here. This is the serratus anterior. So if you follow somebody's serratus anterior back there, you actually get to their medial border. Right? So the serratus anterior truly connects to the rhomboids. And the scapula, really, there are things that helps tie it down to your back and such, but it really is kind of flapping here with the rhomboids pulling the scapula one way and the serratus anterior pulling the scapula the other way. So let me give you another example. This will really help. Bear with me. In some ways, this is closer to the shape of your body, your rib cage, than anything else in some ways. Because you have a rounded rib cage, all of you do. We don't see that because we square it off with shoulders here. But let's put this little guy on here, okay? Actually. So, if this was an actual body, this would be your levator scapula in red, rhomboids in green, scapula here, serratus anterior coming around to the front. And the scapula really can kind of do that, kind of flop around. So if I'm at the front of this body and I'm tracing your ribs around, I can actually go underneath your scapula. And I'm not really hitting your scapula, I'm still on the serratus anterior because it's going to go all the way to the medial border in back. Here's the rhomboids in back. So my hands actually reach there. Why is this important? Because from the front of a body, there's lots of stuff I can access depending on where I'm at here. If I'm rubbing along the rib cage, I'm rubbing the serratus anterior. If I push on the back, what we think of as the back, it's actually the front, the anterior surface of the scapula, what muscle is here? We learned about it yesterday, where I put this X here. This is a rotator cuff muscle here.
I was going to say
Thank you, subscapularis, good job. It is the subscapularis that's helping hook the arm on here. So people get very confused in this, right? So I'll try to give you other examples. But so when you're rubbing my rib, this is my serratus anterior here that I'm rubbing. I know you can't see it. Hold on. But this is serratus anterior. As I go back, if I stay on the ribs and keep working my way around back, which you can only do for so long, but I'm still on serratus anterior. If I hit the back, it's the front of the scapula, I'm actually into like the subscapularis. But the serratus anterior and the rhomboids are designed to pull the scapula front and back. Let me show you a picture that I hope will help, now that you've kind of got that visual. We are going to share a tab. Here we go. Do you guys see, don't worry about the splenic muscle. Do you see the rhomboid here and the serratus anterior here, I hope? Do you see that? Okay. So it's hard to tell from a two-dimensional picture, but they're both attached to the medial border of the scapula. One's just coming from in front and attached to it. One's coming from in back. And so the rhomboids retract and elevate. The serratus protracts and depresses. Right? You can kind of see that one's going to pull the scapula up and the other one's going to pull it back down. Super duper important stuff. So are the rhomboids and the serratus anterior synergists? No. They're agonist-antagonist. They can switch those roles, by the way. Whatever one's working is the agonist, and whatever one's fighting it could be the antagonist. But the fact is, they never work together. I mean, they always work together in weird ways to help keep your scapula in place. But they do the exact opposite stuff. So now, when you are grabbing the edge of a scapula, the medial border of a scapula, what muscles are you grabbing? Who wants to tell me the muscles you are grabbing when you grab the medial border of a scapula? Why can I? Oh, thank you. Ms. McDowell, please.
If you're touching the medial border...
What do you have to go through first? You have to go through something first.
Yeah, the pecs, or in a way the pec major.
The medial border of the scapula. Medial border of the scapula on the posterior side.
Oh, on the posterior side.
Like what you'd actually grab. You've probably done this. You probably grabbed somebody there.
The rhomboids?
Yes, but you already had to go through what to get to them?
The trapezius?
So you went through the trapezius, you grabbed those. When you're grabbing the medial border, you're grabbing the trapezius. Then you got the rhomboids, major and minor. It's possible, depending on how high up you are, that what else did you get back there that's going up to the neck here?
You could get the levator scapula.
Yeah, it's easier said than done, but yes. And what else am I grabbing? If I'm grabbing the rhomboids and I've really actually grabbed the medial border of the scapula, what else am I now grabbing too?
The infraspinatus?
Well, yes, you're absolutely right. But I was also talking about the serratus anterior.
Oh, okay.
Meaning when you grab that medial border, you're grabbing rhomboids and serratus anterior because they both meet. There are one's wrapping around the ribs and coming in front. The other one's wrapping around the ribs and going in back. Yeah. They are the reason that I can protract and retract my scapula. But by the way, Ms. McDowell, that was excellent. You're dead on right. And you're right. You're also, once you're in that area, you're getting infraspinatus and who knows. I mean, you're probably grabbing 6 things. What I call areas of the body where there's like, it's not a particular number, but where there's 5, 6, 7 muscles located there that you can hit all at once, I call that a high priority target. That's a place I can go to and I can get a lot of stuff done by being in that spot. There's a lot of work to be done there. And Ms. McDowell was actually taking it a good step further. She was recognizing that, oh, your hand's already by rotator cuff muscles. I mean, there's probably 9 things there in that area. So that's just why I want us to be aware of that. What are the other ramifications that I have? Muscles that attach to the first 8 or 9 ribs that go underneath my scapula, grab the medial border and back, and then there's rhomboids that go all the way back to my spine. The other ramifications are this. Muscles don't usually cause you problems in isolation or act in isolation. And I've talked about this briefly before, but muscles sometimes argue with one another. So we all know, we've all worked on people probably in this very class, right? We're all probably guilty of this, where their rhomboids and their middle traps are tightened back, right? If they're tight, they're contracted. What's the action of rhomboids when they're contracted? Saw Miss Vincent do it, actually. What's the action of the rhomboids when they're contracted? Anybody in words? Words.
Adducting?
They are adducting. Thank you, Mr. Tate. They are adducting. But I don't see everybody in class walking around like this. Hi, Mr. Tapscott. And yet some of you have tight enough rhomboids, traps to be doing that. So why are you not doing this? Because your body maintains good posture. So what's happening is my serratus anterior kicks in and tries to pull them back forward. So they are tightened back. But remember, if a muscle's tight, it's not actually exercising the action. If it's not showing the action, there's something fighting it. Now, what happens when I have muscles that go from my spine, wrap around my chest, almost to my sternum, and they're tight? Because that's serratus anterior and rhomboids fighting. I now have these nice steel belts around my rib cage, and they're tight. Sometimes it's a little hard to take a breath. Kind of gives me some anxiety. There's a lot of tension. That's a very common complaint to hear from clients. Sometimes I'll ask clients with really tight shoulders, I'll say, is it hard to take a deep breath? And this has happened many, many times. They'll go, it is. I didn't even think about that. I've been breathing really shallow. It's really hard to take a deep breath. Why is that? Probably because you have steel bands around your chest, right? They're not steel bands. They're muscles. But they're serratus anterior and the rhomboids fighting over control of your scapula. And by the way, also doing their job, because part of their job is to, as some of you very astutely put in your homework, thank you, you know who you are, part of their job is to lock down my scapula too. So it doesn't move when I'm typing or doing stuff like this with you guys. I don't want my scapula moving at all. And the way I do that is I make the rhomboids, unconsciously, make the rhomboids and the serratus anterior fight. So they pull forward and back, and that locks my scapula down. And that's very helpful when I want to be very precise here. If my scapula wasn't locked down right now, my hand would not be able to do this. But it's able to because the base is secure. Well, if I type at a keyboard all day long, not only my rhomboids locked down, my serratus anterior is locked down. So how many times have you been to a massage therapist where they worked on your shoulders and they made sure to work your serratus anterior? I don't see a lot of hands raised. Because they don't. Because they don't know their anatomy. So that's why we're learning ours. So now you know that that's something to consider. Let's throw in a little bit more for you to consider. Serratus anterior kind of go down at an angle and kind of come to the front. Serratus anterior. So we know they can abduct or protract and depress. What other muscle did we just talk about up here that can abduct and protract? Abduct and depress. This has to say it out loud. Pec minor. So serratus anterior and pec minor usually work together. They are synergists. And rhomboids and middle traps are synergists too. And these guys fight all day long. And so this is why really good therapists, you know, they don't just rub this all day long. You'll see a lot of this, man. I know people have done an hour on somebody's rhomboids before. They're sure they could just beat them into submission. Nothing wrong with beating stuff into submission, but this is not the whole problem. Boom. Right? If that person were to then turn their client around and make sure to come down here and get into the pec minors and come down here and rub the ribs and loosen up the serratus anterior, it's very likely this person's shoulders would stay loose a lot longer. And you hear this kind of talk, because I've heard this before. I've heard clients say, you know, I don't know what's, you know, better about your massage. You know, John over there works on me, and it feels about the same, to be very honest with you. They're always very honest with me. And I'm like, that's okay. But I keep coming back to you because for whatever reason, when you work on me, my shoulders seem to stay loose longer. And John, they just stay loose that day, and then they come back. Because when John works on them, I hope there's not a John in the class. I know everybody's last name, so I apologize. Because when whoever works on them, they're not stopping the problem. They're just working on the symptom. So I always use this as an example for clients, and I use it for students too, but for clients, I try to explain like these muscles are in an argument, right? And if I resolve the argument with one person, there's still this other person irritating them, and the argument will start again. I have to resolve both sides of the argument. So, So, that is the significance of the serratus anterior and the pec minor that work together, and the rhomboids and the middle traps that work together. And maybe even arguably the levator scapula and upper traps, because they do an elevation too, and you got the retraction back here, and you got the protraction and the depression up in front. And it's all for good reason. All this stuff is made to make this beautiful scapula work around my rib cage. That's really its job. Serratus anterior pulls around the front, rhomboids pull it down the back, and it's why I can do all this cool stuff. Otherwise, I can only do this with my arm. That's it. That's all my ball and socket will give me. But because of the amount of rotation, the amount of movement I got on my scapula, I can get my arm way back here and way over here. That's scapular movement. Because my ball and socket only lets me do this. Yeah. Cool? Cool, cool, cool. Kind of neat stuff. Kind of neat stuff. Okay. I'm going to start the slideshow so we can just run through muscles really quick, just make sure we look at them again. We're also going to talk about a tiny muscle called the subclavius, which you will hit when you're doing the pec minor because of the way you'll probably come about it, which you should. But subclavius actually hooks to like your first rib and underneath the clavicle. And so honestly, when I'm working people, if I ever come to I'll come into your labs actually eventually. And you'll know when you're face up, when you're supine in your spine, you'll notice that when I'm working your shoulders, I bring my hands around front, and I will find your collarbone, and I'll dig in right underneath it, hit your subclavius, trace it around, and get into your pec minors. I always get your pec minors unless you're very guarded or some reason I shouldn't be touching, like if it was too much for you or whatever, but in general, I'm always going to get into your pec minors. I'm always going to cut underneath your collarbone and get your pec minors for sure. It's just a very important area. And remember, the pec minor here could also be pinching down on the brachial plexus. So you could be fighting front to back, the war between the rhomboids and traps, and serratus anterior and pec minor, and pinching down the brachial plexus at the same time. So we're starting now to really explore the shoulder girdle complex. The complex, not like, oh, shoulder, it does this. So, but like this fascinating thing about how all this works and how neat it is. It's very, very neat. Very, very neat. And I haven't even mentioned stuff too, like there's nerves that run underneath your back. We talked about nerve plexes, right? We talked about the brachial plexus, but out of every single vertebrae, there's big nerve branches that come out all the way down. Well, when the rhomboids are tight back here, they tend to pinch down on nerve plexes down your back too. That can cause all sorts of other problems. So loosening up this whole area becomes this very important task of ours. People can tend to be able to breathe better afterwards. When people breathe better, they feel less anxious and anxiety. Those of you that suffer from anxiety know that feeling of and that's not just all in your head, that's muscles tightening up around your chest too. And then once your oxygen is cut off a little bit, now you start to really panic, right? So this is the type of stuff, and this is why massage borders so closely between the physical and the emotional. Because shoulder tension is an emotional thing. I don't mean it's not real. Emotions are the most real thing in the world. Yeah. Okay. Let's show you guys a quick, we're going to flip through slides here. I don't think it'll take long because we've kind of talked about all this, but we'll see. I just want to make sure I didn't forget anything, to be very honest with you. That was the really big, juicy, exciting, amazing stuff. So this, by the way, is a really good picture. Just to let you know how your book does this. I've mentioned this before too, but the left side here is the more superficial side. On the right side, they have removed the trapezius so that you can see the rhomboids. They've removed the deltoid on the right side so you can see the rotator cuff muscles. Okay? They're trying to show you layers, which is important. All right. Same thing here. On the left side, you've got the pectoralis major, which is superficial. They've removed it and the deltoid to show you the pec minor on the other side. And you can see the serratus anterior sneaking out underneath there on both sides. Okay. Rhomboids major and minor. They work off 6 spinous processes. C7 to T5, which happens to be 6 spinous processes. The minor is half the size of the major, so he or she only grabs onto 2, T1 and C7, and then T2 through T5 are grabbed on by the major. But they kind of go up at an angle there, and they attach the medial border of the scapula to the spine. They go at an angle so they can elevate and adduct, add it back to the body. There we go. I actually like pictures like this where they're showing you the origins and insertions kind of just colored here on the left-hand side. There's the levator scapula. Tiny, annoying little muscle. Causes lots of people problems. It is very deep underneath the trap. You can access it from the back, but it's actually easier to kind of try to come in here from the front underneath the trapezius and kind of get to it that way. And boy, does it help to remember that it's attached to the superior angle of the scapula, otherwise you'll never find it. And so I'm often moving somebody's arm around with my finger in here until I bump into their superior angle. That's literally what I'm trying to do. I'm feeling around underneath their trapezius, trying to feel for this thing. All of a sudden I hit this bone and I'm like, oh. And they know it too, because they're like, what was that? I'm like, that's actually your scapula still. It's kind of curved around up there. But anyway, levator scapula. Transverse processes of C1, 2, 3, and 4. Cool stuff. This person's actually kind of doing what I talked about. They're reaching underneath the traps to get to it. Super important muscle. Serratus anterior, we just talked about. You can see why I went through all the trouble to show you how it really attaches, because you sure can't tell from this picture. Just cannot tell. Just doesn't make sense. But you know, I'm obsessed with fascia. Fascially speaking, the serratus anterior just becomes the rhomboids. And the rhomboids just become the serratus anterior, and they've got this scapula caught between them. Hey, my only comment here, they're just commenting about breast tissue being in the way of working serratus anterior and things like that. This is a really clever trick to use. I don't know if it's a trick, but just putting somebody on their side, like they show you there, lets gravity move your client's breast out of your way, right? Because I don't need to be way over here. I just need to be kind of on the ribs. But I don't have to worry about manipulating anything if gravity kind of takes care of that. And if a client's on their side, that's a very effective way. It is not inappropriate, by the way, depending on the relationship you have with your client, meaning they trust you and stuff, to ask your client through the sheet to hold themselves out of the way while you're doing something. The reason I don't like that is I don't like to make clients work. Usually they want to lay there and just take it easy. That's my main reason for not doing that. Most people don't come in and want to actually like, let's stretch and do this hardcore. You'll get athletes sometimes that come in like that and they really want to participate. But most people are like, rub me, I'm going to lay here. I might talk to you, I might not. You make it better. They don't want to help. And that's fine. Yes. Yes, Miss Walker T.
So the serratus anterior, and you were talking about, you know, rubbing it because it helps with the whole, like if their shoulders are tight or their scapula is tight, whatever. Is that something, I'm just kind of wondering how you would work that into
a regular massage?
An hour massage.
Thank you. Thank you, thank you, thank you. What a good question to ask. Okay. Let's show you really quick. Hold on. Because actually what I love about this question is, so you're going to use all this juicy information I've given you guys, I hope. Let's stop sharing here for a second. Juicy information, I hope, for when you've got real problems and somebody comes in, they're like, I've got these chronic shoulder problems. You're going to be like, aha. And you're going to use all this clever stuff to make it way better and be better than other therapists out there because it is competitive, right? No problem getting you a job. That's easy. But we'd like to get you a really high-paying job. I'd like you to be the therapist that makes $100 an hour. So you will use this stuff for your advanced kind of stuff. But you want to take your advanced stuff, like if you're a great cook, you still want to put that into your regular cooking, right? So Miss Walker's question is really good. Like, how do I incorporate this just in my normal junk that I do, Tapscott? And let me show you. All right. Hold on. I just gotta throw a skeleton on the table. Okay. All right. Skeleton come through. Okay. Hold on. There we go. Good. Yeah. Ooh, good. I like it. Okay. Do. All right. Welcome to my client. Kind of. We'll get there. It's happening. So think about this, everybody, because it's such a good question. Like, how do I just add little nuances to the moves I already have to incorporate a little bit of what we learned? So I am sure that you guys are doing strokes down the back, for example. I would hope this is a fairly common stroke that you're doing. I'm working the erector spinae muscles here when I do this. So when we first learn this stroke, we might be like, doot, 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 doot. Don't make that noise. That's just what I do in my massage. Doot, doot. Anyway, that's great. But now, Miss Walker, just as long as I'm careful, just by occasionally, I'll do this, but occasionally I can come back and hit there. And all I have to be careful about, and I'm sorry to be blunt, but I really need to be blunt, all I have to be careful about is not grazing the side of my client's breast, and I do need to be careful. But I've never done it, and I can be careful, and I've got a lot of serratus anterior right here. It's all here. This is the scapula. There's loads of serratus anterior. In fact, I prefer getting it from the back. So now I just put that little stroke into my massage, not every move, but I got that little stroke into my massage, and now I'm already getting some serratus anterior. And now when I do shoulders too, I might also reach under traps occasionally to get in here into the levator too. So I might pull from the side here too, pull the scapula towards me, adduct it more, which is stretching the serratus anterior, and rub the ribs more from back here. So that's some of the stuff I would do to incorporate it. And I love taking basic Swedish moves and just adding more and more to them. So I will give you an example today. I'll remind you guys again later. But this move I consider to be an erector spinae move, right? But I can take this move, erector spinae, I can actually push down here further, go off the sacrum, hit the glutes, because I want to, because I connected to the lower back, we'll get to that later, hit the glutes a little bit at their attachments, come cut under here, get into the quadratus lumborum, kick that back up, come up here, get my occipital region, get some, there's 8 occipital muscles we haven't even learned about that are up here, hit those, come back down around here, hit serratus anterior, come up here, remember I talked about pushing in to the trapezius and getting into the supraspinous fossa? Push into the supraspinous fossa, cut underneath here and get the infraspinatus, and anytime I say infraspinatus you say teres minor, and I've now just hit like 7 or 8 really big important muscles with this stroke. I don't do it on every stroke, but my point is I can add in all these other little things to that stroke, which I think is what you're talking about, Ms. Walker. You're talking about, like, how do I inform my ordinary massage with this? Because even when you come into me and you say, I just want to relax, I'm sneaking that in. Like, you come over to my house, you say, oh, we're just having pizza tonight. Yeah, we're just having pizza, but it's going to be amazing, right? I made the dough myself, and we got all these toppings that you weren't expecting. Right? Because I want to blow you away. So even on your light relaxing massage, I'm still doing therapeutic moves. I'm just not getting challenging with them. I'm not digging in there, but I'm still doing all those areas. And you still walk out and you're like, oh, wow. Yeah, wow. So that's why we do this. Does that answer your question?
Yeah, that's exactly what I was thinking, because I mean, the last 2 days we've been practicing getting through a full body massage in an hour. And then I thought, well, if you're going to have them lay on their side too, front, back, and sides, that would like never work.
Sorry. That was a side comment about moving breast tissue out of the way. And you're right. The only time I've ever done that is when somebody comes in and they're like, we need to spend the whole session on my shoulders. I got this major problem. Then I might have you do all sorts of stuff because we're going to get really into the serratus and really into the pecs and stuff like that. And maybe you're a regular client, things like that. It might just make sense. But you're absolutely right. In my standard massage, where this is very typical, people come in and say, I want a full body and would you spend extra time on my hips? On my feet too. And I'm in there in my head going, I don't even know how to do a 1 hour massage. I can't even get through a body in 1 hour. I mean, I've learned how to fake it. I've been doing it long enough. But to me, I need like 2 hours with your body. I could spend an hour on your feet alone. And so you're right. I'm sitting there going, like, how do we pack it into your massage? And we do that, by the way, by making every stroke count. It's fine right now. I really mean this. So don't let this make you paranoid. I just want you to think about this for the future. It is fine right now if you have what I call wasted strokes. I look for them in massage interviews. It's that stroke where I go, oh, that was okay. Okay. But we don't have time for that in a 60-minute massage. Every stroke needs to be like, oh, wow, they're going down my back. Oh, yeah, that's my glutes. Oh, there's QL. Yeah, oh, serratus anterior. Oh, yeah, super spinatus. That is how the massage should be. It needs to be that power packed. You actually only have time to do like about 10 things and spend 5 minutes on each of them. That's not a lot. You know, and so they've got to be very power packed. And Ms. Walker, what happens to most good therapists is they build kind of a 60-minute massage that then they can adapt, right? They can adapt it to different things, but they have kind of a 60-minute massage they work off of, or 50 minutes. 50 minutes is even better because then you've got some time to do some other things. And then what happens is as you advance as a massage therapist, you go, oh, I've got a great move for this, but I now have a better move where I can get more done quicker. So one of the reasons I like grabbing onto the medial board of the scapula, traps, rhomboids, levator scapula, serratus anterior. Not to mention the stuff Miss McDowell was kind of getting at, right? Infraspinatus, teres minor, supraspinatus is close by. Like I gotta get stuff done. I don't have time for this. Like this is nice, right? But your significant other can do this to you. Right? You don't pay somebody to actually do this. That's fine for the last 10 seconds of your massage. It's got to go, go, go. So anyway, that's what you'll do. Yes, go ahead.
From like a mental mind frame perspective, like an hour massage, if you're doing the full body, is like you would never expect that you're going to loosen things up, but you'd never have the time to really get in and break down like a big knot. So you don't need to worry about spending a bunch of time on a certain knot or whatever. It's just really trying to make every stroke count, get everywhere, good pressure.
There's a lot of things I think about. You're on the right track, by the way. One thing is I always remind myself that every therapist has the same problem, right? This client has been to other therapists and gotten hour massages, and that 60 minutes is 60 minutes. So I don't try to stress myself out. I also know that I'm going to have to really rush over some areas to give more significance to others. Like I'm probably not going to do, I might not do your abs and things like that because by the time we drape them and take time with that and stuff, I just don't know if we're even going to have time. I'm going to do what you think of as a full body massage. I'm going to hit your back, neck, shoulders, hips, legs, brush over your arms and hands, feet, boom. And that's assuming you didn't tell me something that makes me modify that. Now you come in and tell me I use my arms all the time, I want to emphasize them, I'm going to brush over your legs and emphasize your arms. But you're right, I have to do that kind of calculation, and I'm not going to get into major stuff. If it's a really easy body, I might have time to work on one thing. And I will work on whatever you tell me to work on so you felt like I worked on it, but I even try to set expectations for clients. So one of my favorite questions to ask people is, I only ask a couple questions, by the way. And most therapists ask about 400, which is about 350 too many. But I just ask, are there any major medical conditions I should know about? I don't want to ask a lot of questions too because we're wasting time outside the room too. Because the client, if they're on time, by the way, they kind of expect to get their full hour. So if my questionnaire takes 20 minutes, they don't care, right? So any major medical conditions I should know about. And then my next favorite question is, what are we working on today? Oh, nothing, just a regular standard massage. Cool. I'm going to do everything I just talked with you, Ms. Walker, about. Try to do a really good 60-minute power pack massage clean. Skip over anything mild that I can. Your arms and hands aren't getting much. because they're not structural. That's all. I love arms and hands. I love them. Love them. But they're not structural and I don't have enough time. So I'm going to do that kind of thing. If you say something like, oh, no, what are we working on today? My shoulders are killing me. My next question, and I advise you guys do something like this, is, well, is it so bad that we're supposed to spend the entire session on your shoulders? Not that I'm going to rub your shoulders the whole session. I always say that. But I'm only going to do stuff that pertains to your shoulders, which means we may not get to your legs. Or is it really your shoulders are bugging you, but you still want a full body and we should just spend a little extra time on your shoulders? Now, I hear both. They both tell me. But I'm already setting up expectations that if you want a full body, we're just going to do a little extra on your shoulders. I can't make time stop. And clients tend to think that. They're like, well, if I ask for more stuff, I'll get more stuff. You will get more stuff. You'll get less of everything, though. You know? And the transitions take time, too. So, yeah, that's how I handle it. Any major medical conditions we're working on today? Any major medical conditions I need to know about? What are we working on today? Are we focusing the whole session around that? Or are we doing a full body and just doing a little extra of that? Because that's all you're getting. I don't say it that way, by the way. I'm very cordial. I want to make them happy. But I want them very clear. It's 60 minutes. Then I will tell you, by the way, the real solution to this, Ms. Walker, the real secret solution, and I don't know why more therapists don't get this, get them to book a 2-hour. Get them to book a 2-hour. The advantage of a 2-hour is so huge. I know let me lay it out for you again. The advantage of a 2-hour is so huge. One is, even though they know they're getting a 2-hour from you, they will compare it to other people's 1 hours and they can't seem to double the other person's 1 hour. So your 2 hours is always better than another therapist's 1 hour. Always. You will beat them every time. It's not fair. I got 26 years experience. I work on them. You guys get them for 2 hours and they're like, that was amazing. Yeah, it was amazing. They had you for an extra hour. I didn't even get that hour, right? It works every time. Get the hour. Get the hour. Secondly, you don't change sheets. Thirdly, you've already figured out what they need. Fourth, it's actually less work for you. You know the most exhausting thing to do in the world? A 50-minute massage. I don't even breathe. Rub the leg really quick, get down the calf, make sure I'm getting all the layers of the calf, get down with their foot, go back over, flip them back over, but try not to look like I'm rushing the whole time. Make every stroke count, right? 2 hour, I can go slower, deeper, get more done. It's better for the client, but I'm not rushing. I can do my 1 hour massage, but spend an extra half hour on the feet, extra half hour on the shoulders, whatever they ask for. So my big thing is upgrade them up, even at a price reduction. Like if I come to your house for $100 an hour, I'll give you the second hour for $50 even. Because I'm already there. It's $150. You're going to go away happier. I'm going to get a bigger tip. You already used my sheets. I'm already there. I'm right there. We're not losing any change over time. Every 1 hour massage you do, you lose 15 minutes between it and the next one. If not hours, if you have to drive somewhere. So go longer. That's my big thing. Always go longer. Always. Yeah. Yeah. Cool. Okay. Let's go back here really quick, and then I will stop rambling to you guys. But these are very good questions. And very good things to think about. All right, so we talked about pec minor. Don't forget the sign. Right? And here's the brachial plexus going underneath the pec minor. That's why we want to keep it loose. Good stuff. And we did not talk about the subclavius. I mean, I mentioned it. I put a little piece of tape up on a skeleton, but it's a tiny, tiny muscle right underneath the clavicle. If you, by the way, it's very hard to feel because the pec is there too. The pec major is there. We haven't talked about the pec major yet, but the pec major is major. It's big. But it doesn't matter. You don't actually have to locate it. You just rub underneath the clavicle because what's good is you're getting the subclavius and the pec major at the same time. Bam, bonus. So subclavius probably helps to pull down your clavicle. The book does this a lot, by the way, where it says it helps to elevate your ribs during breathing. I don't know. Maybe. It could. Good. Anyway, good muscle to loosen up, though. Keep the rib cage loose. And that's it. Subclavius.
Mr. Topscoat?
Yes, Mr. Tate.
The subclavius, you reach for it underneath
Yeah.
the clavicle?
Yeah, it lives underneath the clavicle. It kind of goes from your first rib diagonally up to your clavicle. And like I said, I can't actually feel mine. I'm not even sure I could isolate it. I was about to get cocky and be like, I can find it. I'm not sure I can. It's underneath the pec major and it's hard to find, but it doesn't matter. I'm hitting it right now. I'm hitting the pec major and it right now. So, you know, I don't really care as long as I kind of hit around that area. I'm always trying to trace out bones. I'm thinking about my massage very much like a butcher. I am trying to cut out your clavicle, anything attached to anything, trying to cut it away, and debone it. So anyway, that's just how I approach it. I know that doesn't sound like a very highbrow kind of way to approach the subclavius, but it's a fairly small muscle, and you hit it every time you stroke underneath the clavicle, and you should stroke underneath the clavicle, directly underneath it. And if you keep your fingers right, this should not violate your client at all, because you should be right under here. It feels good, by the way. Everybody just feels so good. Let's just take a minute to rub our upper chest. Yeah. Cool. All right.